Abdominal pain. There are many causes of abdominal pain, and careful history taking will often lead to the correct diagnosis. The following should be considered. Frequency and duration. Try to determine whether the pain is acute or chronic, when it began and how often it occurs. Site and radiation. The site of pain is important. Ask the patient to point to the area affected by pain and to the point of maximum intensity. Parietal peritoneal inflammation that causes pain usually does so in a localized area. Ask about radiation of pain. Pain often radiates through to the back with pancreatic disease or a penetrating peptic ulcer. It may radiate to the shoulder with diaphragmatic irritation or to the neck with esophageal reflux. Character and pattern. The pain may be colicky, coming and going in waves and related to peristaltic movements, or steady. Colicky pain comes from obstruction of the bowel or the ureters. If the pain is chronic, ask about the daily pattern of pain. Aggravating and relieving factors. Pain due to peptic ulceration may or may not be related to meals. Eating may precipitate ischemic pain in the gut. Antacids or vomiting may relieve peptic ulcer pain or that of gastroesophageal reflux. Defecation or passage of flatus may relieve the pain of colonic disease temporarily. Patients who get some relief by rolling around vigorously are more likely to have a colicky pain, while those who lie perfectly still are more likely to have peritonitis. Patterns of pain. Peptic ulcer disease. This is classically a dull or burning pain in the epigastrium that is relieved to a degree by food or antacids. It is typically episodic and may occur at night, waking the patient from sleep. This combination of symptoms is suggestive of the diagnosis. The pain is often unrelated to meals, despite classical teaching to the contrary. It is not possible to distinguish duodenal ulceration from gastric ulceration clinically. Pancreatic pain. This is a steady epigastric pain that may be partly relieved by sitting up and leaning forwards. There is often radiation of the pain to the back, and vomiting is common. Biliary pain. Although usually called biliary colic, this pain is rarely colicky. With cystic duct obstruction, there is often epigastric pain. It is usually a severe, constant pain that can last for hours. There may be a history of episodes of similar pain in the past. If cholecystitis develops, the pain typically shifts to the right upper quadrant and becomes more severe. Renal colic. This is a colicky pain superimposed on a background of constant pain in the renal angle, often with radiation towards the groin. It can be very severe indeed. Bowel obstruction. This is colicky pain. Periumbilical pain suggests a small bowel origin, but colonic pain can occur anywhere in the abdomen. Small bowel obstruction tends to cause more frequent colicky pain, with a cycle every 2 to 3 minutes, than large bowel obstruction, every 10 to 15 minutes. Obstruction is often associated with vomiting, constipation, and abdominal distension.